All right, welcome everyone. So we have our tute this week, and then we have one more tute before we have our first online assessment. So we've obviously got our quiz, and Anita and I have been talking about the format of today's tute, where we've got the workbook that I've just uploaded onto Milo, and we're going to go through each of the ECGs in sort of one as a bigger group, and then we're going to go through them in smaller, I don't know, mini groups or whatever, and then present our findings based on using sort of the 10-step method and explaining a bit about the pathophys behind what you think is happening in your ECG. Aside from that, there's a few questions I just saw on the Padlet, which Anita and I might try and filter while we're going through the tute throughout today. But is there anything else before we get started in general about the plan? No. All right, so to start off with, we might just pick up the first ECG and go through that one as a group, which should be a good way to kind of start off with today.
Are you projecting that onto the screen, or how do you want to do it? Because all that we can see online is you at the moment. And
hang on a second.
That's all right. I didn't know which way you wanted to go. Yep, we've got a screen sharing, double click to enter full screen mode. There we go. Got an ECG up there now.
How are we looking?
Yep, I can read. I've got a, I haven't got a number on it. I won't say what it is, but retrieved from Cashow et al. 2024. It says it's 12 lead.
All right. Okay, so on your online learning, we talked about how to access up-to-date. Couldn't access the PEDS rating. I will get onto that, Chloe. To start off with, I know that you guys have been through most of your online sort of content. So in terms of where we start off with, in terms of our rhythm interpretation, we've gone from our 5-step method, and we're just adding in a few more elements. And we talked about axis deviation last week, and about the different views of the heart, the different views on the different leads. So to start off with, where do we start with our rhythm interpretation? Does anyone want to pop into the chat or? Oh. Great, perfect.
Got rate rhythm coming out from Chloe on chat.
So I had an email from someone about sort of the best methods to interpret the rate. What's everyone's interpretation of their favorite method to do and why?
I've been using the 300 method. I think it's a quick one. 300
method from Tal. So do you mind explaining that, Tal?
Yeah, so I just kind of count the blocks. So each block is 300. So if it's 2 blocks, it's 150. 3 blocks, it's 100. 4 blocks, 75, etc. So 300 divided by the number of big blocks.
Perfect.
Assuming it's regular, yeah.
Yeah, I was going to say, if it's an irregular rhythm, that's going to be a hard one to use,
yeah.
isn't it?
Yeah.
Michael, you've said the 6-second method. How do you go about that one?
Sorry, count 6 seconds on the strip, which is 1, 2, 3, 4, 5, 6. Looking at lead 2 down the bottom.
Yep.
Count the curious complexes and times it by 10.
Perfect. Yeah. What's the good advantage of that method over the
Can be used if it's an irregular rhythm.
Yeah, for sure. And especially, obviously for us when we're sort of trying to interpret things a little bit faster. I mean, obviously the machine does a lot of interpretation for us, but yeah, I would probably agree with you, Michael. I'm probably a bit more favoured of the 6-second method for exactly that reason, that you can navigate the irregularity of the rhythm pretty quickly. The only time is if you have, well, I guess if you have bradycardia being that bad, then you're going to be putting the pads on anyway, but that can also just make that difficult. So doubling the method as well can also work.
Sorry, if I could just ask you a question, Georgie. Sometimes we don't have, on the ECG, we don't have that bottom lead 2 going all the way across. So how do you work out what is 6 seconds then?
It's a good question. So ideally you'll have the lead 2 at the bottom, and for your quiz, we'll make sure that we have ECGs there that have lead 2 at the bottom. And or your quiz would be just interpretation of lead 2 as well. However, in saying that, your ECG rhythm, so the different sections of your like your 1, 2, 3 and AVL and etc., are not necessarily correlated to time. Is this correct, Anita, in saying that it's 2.5 seconds and then it's 2.5 seconds each one, but it depends on the ECG machine?
So what was the question? If you've got the lead strip across the bottom, you can choose when you're on the
If you
whatever
don't have the
machine,
lead strip on the bottom.
you can choose whatever strip you want to run on the bottom as your main monitoring lead. Most people will use lead 2, but it comes back to the fact that how much is each, if it's calibrated properly, which is the first point when you start with an ECG, make sure it's diagnostic. So therefore every ruler that you use is going to be correct. So how much is each one of those, when it's calibrated correctly, how much is one of those small boxes worth in time?
0.02.
So each,
0.2.
yeah, 0.02. So if we've got 5 of those large boxes equals what? 1 second, doesn't it? So therefore, if you go along the bottom there and count it out, if I've got a 6-second strip across that bottom, how many boxes? So we're looking at that strip there. You usually start where you've got a complex or start on that lead 2 across there and count how many boxes have you got. So for instance, start on a big box. So you can see on lead 2 where you've got that QRS that's just come in. I'd start on that line, that's that box that's just come in there. Now, how many boxes across will you count for a 6-second interval of those big boxes? That makes sense to everyone? Because how many boxes across the bottom there? I'm sorry, my cursor doesn't work, but how many boxes is 6 seconds across of those big boxes? When there's 1, 2, 3, 4, 5, we can see in one grid sort of element. How many of those do we need? Yeah, that's true. It depends on the monitor. You can put any lead down there as your monitoring lead. You can put AVL down there if you want. You select what you want. It's normally at default is lead 2 because that's your main monitoring lead. So my question is, if we're not sure where 6 seconds is, and the idea here is to count the QRS complex or the R complexes in that strip, we have to know how long that is. So how many boxes is 6 seconds?
6.
So 6 boxes. So of the large boxes, 1, 2, 3, 4, 5, 6, is that correct? So each one of these little tiny boxes in here, right? Each one of these little bubble boxes, so shall we say, right? How much is that? So one of the horizontal, see inside there, one of those little tiny horizontal boxes in there is worth 0.04, isn't it? So therefore one of the large boxes, we've got 5 of them in there, equals 0.2 of a second. So 5 large boxes equals 1 second. So if you count that out, how many is, maybe you can explain it better, Georgie. I'm trying to sort of make sure that everybody, because if you haven't got the markers on there for your 6-second strip, you might actually have to count it out there, especially if it's a slow sort of rhythm. Do you know what I'm trying to say? I'm trying to get people to measure I use that, Michael, I also use that method as well because it's good in the sense that you can cater for slow rhythms, fast rhythms, and irregular rhythms. But if we look at 25 millimeters per second for this paper speed, so that has to be right. Otherwise, our timing's going to be off. So each one of those 1 millimeter horizontal box equals 0.04 of a second. So each large horizontal box, the width of 5 smaller boxes inside, should equal 0.2. Therefore, 5 large square boxes equals 1 second. So how many?
So it's 30 of those small ones,
Well
or
done.
6
Yeah.
of the
Okay.
big li-
So we
of-
want,
of
yeah,
6
we
of
want to
these big
count it
lines.
out on the actual paper to be able to go, okay, well, there's where my 6-second interval is. Is everyone okay with that?
Sorry,
Yeah.
Nina, I think I asked my question. With regards to this with regards to like lead 1, 2, and 3, and then these sections, these are not correlated to time, are they? Because they're 2.5 second. Is that right? 2.5. There should be about 2.5 second block.
Yeah, it's showing you as
Blocks.
it's running across in time, but it's not a full lead strip, is it?
Not a
Because
full
that's
lead strip,
showing down
yeah.
on, that's why you have the lead that runs at the bottom there as a full, that will give you that 6-second interval at the bottom there. Whereas those ones, you could argue that it's running across in time, but it's looking at different planes of the heart, which is why we use that strip at the bottom. And you can override that and put whatever strip you want down the bottom there. It could be AVL for instance.
Yeah. So you can't use all of the, like, you can't use each of these sections for your rate interpretation. You still need to print out.
It would be
Print out.
ideal to, yes, to print out across the bottom, because remember, the beauty of what you want to look at is the pattern over time. And the smaller the pattern I've got, the less I can see, especially when you're trying to diagnose a block, for instance. You need that pattern to exist. And that's why you've got that 6-second strip at the bottom.
Thanks, Jazz. That's a really good 0.2, 1, and 5. Okay. So based on either method or of any which way, what is our rate based on whatever method you're using? No, I need to actually. Would this be best to use when calculating? Yes. Yeah. Okay, so we've got about 40 beats per minute from everyone using a 6-second method. Is anyone getting anything different? Yep, so we got 40. So what's our next step beyond the rate? What do we need to calculate next? Regularity. This is just the regularity of our QRS complexes. We calculate. You guess so? So if we're calculating regularity, are we just looking at our QRS complexes, or are we going to be looking at our P wave regularity as well? Why is that important to know? Both from Lucy? Yep. Both for heart blocks, fantastic. Mainly QRS, but P wave should be present. Absolutely, Jazz. Yes, because you might have a 3rd degree. Absolutely. Okay, so what's is our rhythm regular from this one? QRS is, but the P's all over the top. Okay, so what's our, I really want to touch this screen. What's our regularity from, or what's the distance between each of our QRSs and our P's?
It's a variable.
Yeah. Variable?
Yeah.
Agreed. For both P's and QRSs?
Distance between the P's and the the P and the R is variable, the distance.
And what about the distance between the P and the P and the Q and the R and the R?
So the R and the R are regular, but the P and the P are irregular, if that makes sense.
Yeah, absolutely. And what does that tell us?
Somebody else has to say.
Atrial 100, QRS 40, fantastic. Harper, yeah, absolutely. Problem with the AV, absolutely. Madeline, AV block, yeah, absolutely. So if we have a different rate going between our R to R and our P to P, but if they're happening independently, we know there's a problem potentially around our AV. If there's a problem, if our QRS complex is irregular, then we know that we don't have very good ventricular capture. But if we have a regular P interval, then we know that we have a regular firing from our SA node. So that's why it's important at this point to know, relatively speaking, is it regular between our R to R and is it regular between our P to P, to try and work out where exactly that's originating from. All right, so then we need to look at our axis. So from last week, how do we go with our axis and what do we need to look at? Bring up. Lead 1, 2 and AVF, absolutely, Jack. And what are you looking for in lead 1, 2 and AVF? So which lead should we see our most positive? Yeah, cool. All positive equals normal axis. Yes. Although we have a slight negative deflection in lead 1, but that's potentially normal as well because it's mostly positive, but yes. All right, so beyond axis, what about our P waves? What do our P waves look like? Peaked. Normal. How would we determine if they're normal or not? What are we looking for? Yeah, present, upright, rounded, similar shapes, so coming from one pacemaker. Absolutely, Zoe. So we're looking for them to all be, sorry, it's nice and big here and really small on my screen. Looking for them all to be the same shape and size. Do we think that they're all the same shape and size in this bottom lead 2 rhythm strip? They seem to all be similar shapes, so maybe coming from one pacemaker. No, from Jack. Seem to be the same length. Some are more peaks than others. Yeah, one seems bigger and one seems smaller. Yeah, I'd probably agree with Zoe. I think we've got two different P waves here, so potentially two sites. I think we've got this one here, which is maybe a bit more peaked, and then this one here, which is potentially a little bit flatter and more. Maybe not actually. Would you agree, Anita, or you think that they're the same? No, they're definitely different.
Morphology looks quite similar in the sense of what they are, and if you pace them out as well.
Yeah.
I mean, it's hard because they're in the other complexes as well.
Yeah.
But if you look at third, like if you go along to the end, you can see you've got two clear ones between the you see the last QRS complex on. Yeah, these two look probably the best run of them because the next set are going to be buried.
One seems bigger and one seems smaller. Which one do you think looks bigger and smaller? Sorry. Because we do have our T wave, which is potentially.
Me, I'm looking at the ones in between. So if you count the last QRS complex, between the third and the second last QRS complex, look at the Q waves. Sorry, look at the P waves in there in that section there. They look quite similar.
Yeah, like these ones.
No, next these two, yeah, and keep going. All right, yeah. The morphology is more similar than dissimilar. I agree, they're not identical.
Yeah. So potentially we have two sites maybe for our.
If that's
potentially. but they do look pretty similar. The only thing is that they're not very regular as well. They do look pretty similar to you. Yeah. Madeline, I think you're right. I think that they are pretty similar. And normally when we'd see a large difference in our P waves, they'd be a lot more obvious especially in their distance of the length of the P wave as well. Whereas these ones are similar height, similar length.
Amplitude similar, yeah. They're more
Yeah.
similar than they are dissimilar, put it that. I'd sort of say that. You got a hand raised there, Georgie, as well.
Yeah, go on, Tal, yeah.
Sorry, everyone. Question, for example, right at the end of the strip, how do you distinguish the P wave from it being potentially a T wave?
Good question. Are you talking in particular this one here?
Yeah, for example.
So with that is a very difficult one to determine, I would agree. But with your T wave, sometimes the T wave can hide a P wave firing as well, but you won't see then atrial depolarization because you'll be looking at the ventricular repolarization, which will be overshadowing the atrial depolarization. So you won't be able to then see it. So then that would be a T wave because you do have to have ventricular repolarization. And so that's what you'll see overwhelmingly on the ECG. So that has to be a T wave, but potentially your P wave would be hidden by that amplitude, or might change the amplitude of the T wave in that particular one. Does that make sense, Tal?
Yeah, it does.
Yeah.
It doesn't help detecting it, but it does make sense.
Yeah, so basically you have to have the T wave following the QRS, so you're going to see that, but you might not see the P wave if it's been hidden by the T wave.
Got it. So it might change the shape of that T wave.
It
Okay.
might, depending on,
Okay, cool, thanks.
and we do see that because we see a different shaped T wave in all of those leads. So for example, the shape of this one compared to this one, they're all different sorts of shapes. So potentially, to your point, like we're not seeing the P wave properly because it's being hidden in that way. Is that, yeah? John?
Yeah, thanks. Just asking more so a question if this is correct, but because I'm sitting in front of the computer, I've sort of always been taught to use it. I can't see them.
Sorry, John, you just cut out.
So, sorry, I was just checking whether I've always been taught to use a piece of paper where you can mark the P waves that you can see and then slide it left or right, and that helps identify if you've got P waves hidden underneath the T's or complexes. Is that reasonable?
Yeah, so ideally you can mark, to explain what John is talking about. You guys got
A
one,
good
have you?
way to pick up patterns. You're right, John. Yes, you can mark it and slide it along and use
Yeah,
different levels to.
because only I'm in front of the screen and I've mapped them out and they're sitting at 100 beats per minute on the P waves, and complexes are at 38.5. So the dissociation, but you can see where they should be by sliding.
That's the other thing. You can find the pattern for the P wave because it's
Yeah.
obviously atrially. There's an atrial rate here and a ventricular rate. Yes.
In your textbook should be an example calculator, but I can't find it. If I work out the page, I'll try and work it out at a different time. But basically, in your textbook will be an example of an ECG calculator where we used to use that piece of paper, which is the method that you're talking about, John. Now we usually rely a lot more on the interpretation from the machine in terms of regularity and rate. But the ultimate method is to use the piece of paper method that you're talking about. Sorry, I'm going to have to go and find it after class. But yeah, the ultimate method is to just use the piece of paper and, to your point, print out an extra strip or just pull out some extra paper and then just pop it down next to the ECG strip and just mark those, the P, QRS and T wave, and then just keep comparing that along the strip. And that's the easy method to just quickly determine if it's regular or irregular as well, if they're the same. All right, so we've determined our P waves are pretty similar. We've got our axis is normal. What about our PR intervals? Irregular. Yep, sometimes for long, sometimes short. Once it's okay. Okay. Is anyone confident that the varied or dissociated? Yeah, I agree. Sorry, there's no longs can indicate AV block. Yes. So we got a regular pattern in our P wave to QRS complex.
I can't see a pattern. That's why I said third degree earlier, because I can't see a pattern.
So on our first one, we have one P wave, then we have two P waves, then we have two, and they're not really, maybe three actually, no, two, they're not associated. We have two more, they're not associated. So there's no real pattern. Is anyone in disagreement with that? The pattern, yep, agreed, Jack. All right, so we're suspicious it's third degree. Yeah. Agreed.
But then you have got a pattern for the P waves. If you map those P waves across, they are regular. They occur inside the QRS, don't they? And inside the T waves. But if you map them across, are they regular, or are they in a pattern, do you think, Georgie?
I don't think that they are.
Okay.
No, I don't think that they are. 1, 2, 3, 4, 5. They're about 3 big squares each. So QRS is 1.6, P is about 0.6. Amazing, thanks for the quick maths, sorry. Okay, so if our P waves are regular then, is it complete heart block? Yep. From Sam? Yep. From Jack? Yep, absolutely. Cool.
Is this you say complete heart block, you mean third degree heart block?
Third degree, yeah.
But then wouldn't you, if you've got, then you would have two independent patterns, then you would have a regular P wave pattern, and you would have a regular QRS pattern, wouldn't you?
Yeah, but we don't have any regular QRS pattern. We do actually.
Those QRSs are equidistant from each other, aren't they?
Okay, yeah, well then it's not complete heart, not third degree then if we have a regular independent P wave pattern and a regular independent QRS wave pattern, we just have atrioventricular block. So then we have our S wave working perfectly, we have our bundle branches working, but we just don't have that connection or the AV.
Correct, yeah. Oh. Is that what this is, third degree or complete AV block?
Complete AV block.
So there's no lengthen drop for these P, and there's no multiples of ratio to P waves that are in pattern to a QRS. There's no extended P wave PR intervals. So there's no first degree block. But I'd argue there is a pattern of P waves there independently to the QRSs, which are also regular. So therefore you've got upstairs in the atria having a party, it's firing regularly, but because you've got complete AV block, it's not getting through to the AV junction. But it's interesting that the QRS is, so it must be a high up block because that QRS is quite narrow. It's not broad.
Yep, absolutely.
Is that what you're thinking?
Yeah,
so it must 100%. Be near that, or up near the hiss. I'd imagine that's happening.
Yep, agreed. So is anyone else in disagreement with that?
Sorry, just to clarify, Anita, so if the P wave is regular and the QRS are regular, but they're not in sync, then it's an AV block. But if it's a third degree block, neither will be regular?
So when you say AV block, there are different types, aren't there? There's first degree, there's second degree type 1, there's second degree type 2, and then there's third degree, which people use as complete AV block. In there, you've got the atria that are in the atrial part of the heart. You've got a complex that's occurring, a P wave, and in the ventricular part of the heart, you've got complexes that are occurring. But what's happened here is that you've got no conduction between the atria and the ventricles. I don't know. I mean, I don't know, Georgie, if you want to explain this, but you've still got atrial complexes on there because you can clearly see upright rounded P waves. They're coming from, they are atrially driven, but they're not getting through. In other words, the P wave does not cause the QRS complex. The QRSs are occurring, they're occurring in their own rhythm, and they are regular. I mean, you'd have to pace them out, but they look regular to me, which means that it's a regular ventricularly driven rhythm. The only output this patient would have would be bradycardic. But that, I mean, that's the definition of a third degree block. They've got no, that's why it's called AV dissociation. There's no complex from the atria that gets through, that starts the QRS. Is this a third degree? Have you got the answer there, Georgie?
It's complete AV dissociation.
Yeah, so here you've got a third degree heart block. So in other words, with that sort of rhythm, you want to pace out. You want to look at it like there's two horses in this race, the atria and the ventricles, and neither of them, it's like there's a dance party upstairs in the atria, and those complexes cannot get through to the ventricles. That's the definition of a complete AV block. So you measure on that bottom strip, look for the pattern, and those P waves should be regular because they're firing off. But the problem is, if they happen to land next to a QRS, that's just by coincidence. They did not cause that QRS. Then you look at the ventricle rhythm, and that should also be regular. In this instance, it's a narrow one, so I'd argue that the generation for this rhythm is occurring high up in the hiss or at the top part of the ventricle. But here, they've got two things that are occurring independently. The atria does not communicate. It's like someone's poured cement through the center of that junction there. Does that make sense?
To maybe expand on your point, Anita, we can have different types of third degree block.
Absolutely, yes.
And we don't necessarily always have a third degree block, which is everything is firing all at once and there's no pattern. We can have a pattern within our third degree block.
Absolutely,
and that's
yeah.
probably where we're seeing this confusion. But is that sort of answering that
Yes.
question now? So effectively, we can have a pattern between our P waves and our independently of our QRSs, and that's still a third degree block, but we can also have P waves firing randomly and different sites all over the atria, and we can have our QRS complexes firing, and they can be wide, and that can still be a third degree block as well. It's just that in particular, this particular pattern we're recognizing is potentially an AV block because we're seeing that P waves are independently having their pattern, and the QRSs are narrow and having their independent pattern. So it's an interruption stopping the electrical. Yes, absolutely, Jazz. So we know that's where the side of the block is occurring. And obviously we've been talking about the different sorts of patterns that we see in our different rhythm strips until now, but now we're trying to get a bit more specific about where exactly we're seeing these issues occurring. Yes, it's blocked. So could you show an example of an irregular complete heart block? I'll bring one up in a minute. Zoe, we'll get into our activities and then we'll get going.
Sorry, I didn't mean to confuse the issue.
No. I think it was good that it came up because it is important to clarify. So getting on with our 10-step methods. The next part that we need to start looking at is our ST segment. So it helped. Okay, amazing, Madeline, great. So in terms of our ST segment, what do we sort of need to look at in terms of that part of our ECG? And is it just one rhythm, one view that we can look at?
You hide off the isoelectric line contiguous leads.
Absolutely. And what do you mean by contiguous leads?
Leads that are next to each other. Like the views that are next to each other.
Good question. So does everyone know the terms contiguous and reciprocal?
The facing and things that.
Yeah, you were close though. Has anyone got any ideas about, is it ever so slightly depressed or elevated? Yeah, absolutely. So we're looking at we can't hear Luke very well. Sorry, Madeline. So he said, we need to look at the differences between the contiguous and the reciprocal leads. But even before we look at the contiguous and reciprocal, there's some points here about looking forward to see if the ST segment is elevated or depressed. So what do we observe from this one? Is it isoelectric or elevated or depressed? No elevation or depression. Dips from the isoelectric line a little bit, absolutely. So in our lead 2 rhythm, we can see that our J point is isoelectric, and that's pretty consistent across most of the leads. Is there any leads where that's a little bit questionable, or are we pretty happy that it's pretty isoelectric across the board? B4 and 5, yeah, I would agree with that. 2 to 6 depressed. I think. I'm not sure if it's 2 depressed in B2 to 6. I think it's pretty isoelectric B2, but definitely B5, we're seeing some depression maybe in our J point, but in terms of what we're looking for in terms of our J point, let's see if I can, so we're looking over here, so this is pretty isoelectric here. Hang on a second. Sorry. So we're pretty happy that's isoelectric there. We're about one along the lines there. If we're looking at our isoelectric line here, we're pretty happy. If we're looking at our isoelectric line here, maybe we're a little bit depressed, and maybe a little bit depressed there as well. Is anyone in disagreement about that?
Is there a tolerance? For example, is it one block okay, one little block okay, or is it absolute when you're seeing if it's elevated or depressed?
It's a good question, Tal, and we're definitely going to talk about it a little bit more when we're talking about ACS. But there are different thresholds for different populations and different groups. So depends on your age and your gender in terms of what we tolerate as depressed or elevated. But in general, yeah, less than 1 small square is not a big deal. Yeah, there we go. So Anita's just said. So in general, we're pretty happy with our J points across the board. What about our T waves? Are they normal or not normal? And can someone describe them for us? Pretty irregular in lead 2.
Shape-wise.
Yep, definitely irregular shapes. Deeply inverted in V1 to 3. Yeah, absolutely, Chloe. Inverted in V1 to 4. Yep. Anywhere else that we're seeing them a bit abnormal? Lead 3, yeah, absolutely, Zoe. So we have T wave inversion in lead 3 and V1 to V4. And we have an irregular pattern for our T wave as well in lead 2, which is very suspicious. So going back a tiny little step to go and talk about what that means. Well, what does it mean, I guess, in terms of our T waves being inverted particularly? What does that represent? ischemia, yeah, potentially, John, yeah, absolutely, yeah. Yeah, okay, so from Luke, we have repolarization happening in the wrong direction, from, yeah, irregular repolarization. So effectively, if we're looking at especially V1 to V4, we know that those leads are going to be our chest leads. So we know that direction of travel is now happening, rather than happening, our repolarization happening from the ventricles up, we potentially know that that direction is happening now away from those leads. Especially if we look at lead 3, which is very suspicious, we know that lead 3 is going to be this direction here. See that? So we know that that direction is now happening away from that that lead 3. Sorry, lead 3 is this side. We know that the direction is going to be happening now away from that side as well. So potentially, to Jay's point, there can be a lot of different causes to that. It can be electrolyte imbalance. We can see it's because of ischemia. It can be the main sorts of causes, but some sort of reason like that. And then what that makes us suspicious of now is that ischemia happening, which is resulting in the normal pathway happening, or is that ischemia happening to the point that it's because of a reason with the electrical conduction pattern of the heart? And we looked at V1 to V6 before, and we knew that, we looked at the rhythm before, and we know that there's a dissociation. We know there's an AV block. So now we're suspicious that our pattern for our QRS complex, so our depolarization is not happening normally, maybe because of this bundle branch, because of the AV block. So now we need to see, is there going to be a block in both our right and left bundle branches as well? So that's what we're going to start to look at now. Is everyone following so far? Just going to get a general pattern. So in terms of looking at our T waves, we know that they're abnormal. So now we need to go back and have a look at our QRS complexes. So our QRS complexes, are they mostly, so we've determined in lead 2, we're happy that they're normal. Are they normal across the board, or are they a little bit strange in our chest leads? A bit peaked in V2, V3? Yeah, absolutely, I agree. Anything else from anyone else?
Yeah, babe.
Yeah,
Oh.
go on.
Video.
I'm on the video, but I'm not.
Go on, Becky, is that one?
Sorry, that was an accident.
Okay, no worries. So our QRS complex is normal from anyone else? V1 to V6, check for block. There are 2 R waves in V1, right? Like RSR. Absolutely, Zoe. So when we're looking at our QRS complexes, we talked about last week about how there should be a pattern of our R wave progression. So we should see, rather than have a QRS complex, potentially we have a RS, or we have a small QRS. So normally when we're talking about our leads, if we talk about a small Q, we're talking about a small deflection of the wave. If we're talking about a large Q, then we're talking about the large deflection of the wave. And the same for the R and S as well. So in terms of our lead V1, to Zoe's point, we're looking at potentially an RSR pattern in V1, which is very suspicious of a bundle branch block. So if we see that in V1, we have this RSR pattern. What other lead do we need to look at to see if the bundle branch block exists? V6, yes, absolutely, Bronte. And what are we looking for in V6? nothing. So we're looking for it to, yeah, absolutely, QRS and a slurred S wave, yes. So we're looking for the Q and then the large RS pattern. So we still should see that mostly positive projection of the R, and then this slurred S wave, which we do see a little bit of in V6, but potentially if you don't see a proper slurred S wave, then you might be suspicious that it's an incomplete bundle branch block. So that could be why that's occurring there. Rounding of the QRS. Is that consistent with what you're trying to describe, Madeline? Yeah. So obviously, if we're looking at a left bundle branch block, then we're looking at the opposite. We're looking at that patterning happening in V6 and we're not happening in, or the slurring in V1. Width of the QRS is also important, as you said. Yes, sorry, Anita, I forgot to point out to that. So in particular, we're looking for these bunny ears. So if we were talking about our QRS complexes here, we're happy that those QRS complexes are less normal, less than 0.12. But if we're looking at our V1 and precordial leads, sorry, we know that our, I don't actually know, maybe four squares, 0.18, the QRS complexes are. So we're suspicious that that's going to be a bundle branch block, and that's why we need to confirm that. So in summary, we're coming up with our overall pattern of how we're going to describe this ECG, and how, does anyone want to put it all together?
I don't know what you described first.
So we normally describe, good question. So we normally describe our underlying pattern first, and then we would describe those additional layers as well. So we'd say this is a 3rd degree Hart block with potential, or dissociated AV block with potentially a right bundle branch block as well.
You don't need to describe the speed.
Yeah, you do. Yeah, and you would say the speed as well. Now Anita's put in the little trick for how we determine the difference between our
I'm just trying to find the left and the right. I'll get back with a little chart. I put left in first, then right. So I'll try and find one with both in there. But is this a complete or incomplete right?
I think incomplete because it's
Yes, the QRS
Yeah.
is not wide enough
QRS is
to
not
be
wide enough,
complete. Yeah, it has to be wide enough to be able to so greater than 0.12 of a second QRS width. It's not, so it's incomplete.
Because that would indicate that the rhythm is coming from the ventricles, because there's literally nothing getting through.
Yeah.
Or because it's incomplete, the QRS is a bit narrow.
something getting through. Yeah, yeah. There's some conduction happening. Yeah, and we can see that because of lead 2, right? We can see some normal patterns there.
Yeah.
So Anita's just put in the William Morrow explanation, which is a little trick on how to determine bundle branch blocks. But effectively, if I type it up, then it makes a bit more sense. So effectively, what we're talking about is if you're looking for a left bundle branch block, in V1, you should see a W pattern in your QRS complex. And in V6, you'll see an M pattern in your QRS complex. And just the same for right bundle branch block, then you see an M pattern in V1 and a W pattern in V6. Yes, John. I don't know about that.
I put left in first, sorry, and then comes right.
Yeah. All right, go for it, Imogen.
Just with the incomplete versus complete right bundle branch block, which QRS has to be narrow for it to be incomplete? Is that just in lead 2? Because it looks like V1 might be wide.
Yeah, so V1 is wide, but in V6 we see that as being normal.
Oh, so they both have to be wide to be complete.
Yeah, that's my understanding. Anita, is that?
Yes, overall. So you're looking at it, and you can see there that the inverted T wave has altered that, and that's what you'll get with that reverse repolarization. That will affect that QRS width. So overall, looking at it, but it's your V1, V1, V6 that we're looking at there. But you can also look at V2, for instance, V5, because they're lateral versus septal leads as well. But yeah, overall, the QRS complex is not wide enough, so it's incomplete. It is there. There is some sort of conduction delay through there, but it has to meet criteria of having that usually characterized by that wide QRS greater than 0.12 of a second.
And that has to be in both V1 and V6, not just one of them.
Having a look at it there, it's not wide enough to make criteria, correct?
Okay, even V1?
Yeah, so to be complete, I think, yeah. I'm gonna need to get back to you on that, Imogen.
Okay,
No knows.
cool, thanks.
So Nathan's raised a good point there about how we rotate ECGs as well. So that's another sort of like trick that we can use, especially because we obviously have a printout. If you point the ECG, you might even be able to. Can I rotate it? No. So if we point the ECG up, then the direction of what direction your leads are pointing can tell you whether or not you're suspicious of a right or a left bundle branch block. So if the leads are mostly pointing to the QRS complex, is mostly pointing to the right, then you can see that that's the right bundle. And then if it's, for example, if it was mostly down here in B6, it would be pointing to the left, then you would be suspicious of left bundle.
There's an easy way to remember it, in a sense, is if we look at the polarization of what's happening. V1, is V1 normally a negative or a positive lead? Overall. So is V1 a positive lead overall, or is it negative? Normally, in normal life, is it normally a more negative lead, or is it in a normal world? Is V1 more negative or more positive? So usually with the V leads, you start at more negative and work around to, it becomes more equiphasic at V3, V4, more positive 5 and 6. So here you've actually got a positive deflection in V1, haven't you? Which is, and that is not, so you've got higher, it's more positive than it is negative. So that's abnormal. So a quick way to look at it is if you're looking for right bundle branch block, this will be a positive deflection in V1 overall. Whereas if it's got a left bundle branch block there, you might bring one of those up later, Georgie. You'll see that the V1 will usually be negative as it in life as well. So V1's a handy lead to look at. We look at it anyway for the width. And yes, to answer your question before, it's going to be both V1 and V6 that we need to see those changes in for a right bundle branch block with the RSR complex and the width there as well. Because remember, you're looking at both aspects of that to be able to diagnose it.
So to that point, what do we expect that this patient would present like?
Sorry, Georgie, I didn't hear your question, and I'm not sure if we did online either.
Like, how would our patient present in this instance, or suspicious of? They might feel palpitations, yeah.
Fatigue. Uncoordinated.
Is the uncoordination? Yeah, absolutely. Anyone else? Fatigue, dyspnea, absolutely. Yep, absolutely.
Is this sort of Brady? Would they be like a little bit less conscious?
Yeah, potentially. So maybe a reduced GCS, chest discomfort. Yeah, I mean, at the end of the day, we have a bradycardic rhythm, so we potentially don't have enough cardiac output. We've got our reduced SpO2 potentially, and to Luke's point, maybe reduced GCS. There's a bit of discussion here about chest pain and palpitations. Yes, although maybe not. Maybe there's that juice. Yeah, it's unlikely that it's not ischemia, not pain. Yeah, so we'd be expecting that this patient would definitely present on bordering on cardiogenic shock or heading that way. How well perfused would they be potentially? Yeah. Good question, Anita. So would we be administering GTN is Anita's question. If they did have chest pain. So I know what the blood pressure is, no. But yeah, even if we didn't know the blood pressure, it would still be risky to be giving GTN in this patient because it's Brady. Yeah. Alrighty. Are there any questions from that? Obviously, it's a really complicated ECG to start off with, but it does show lots of different things that we are able to sort of talk about. And everything else is going to look easy now compared to. So, yes, to Nina's point, our stroke volume and our heart rate is going to be a problem here because we won't have any stroke volume because the atria obviously not conducting with the ventricles. So a cardiac output will very quickly become a problem. All right, so in our groups, we're going to try and do an ECG interpretation each. So there's 10 on the worksheet. So we'll break you up into maybe groups of 2, I think, maybe 3. How many people have we got? 31. So 3 people per group. And if you're group 1, can you do ECG 2, and then so on and so forth. Oh, and we've had some people drop off because they don't want to do group work. And then we'll come back and discuss as a group, and each group can present their ECG if that's okay. Does that make sense?
Sorry, where's the worksheet, Georgie?
It should be on Milo on the tutorial page. So, sorry. Let me just see if I can post the link. Or if anyone gets there faster than me. Right. So it should be 3 point.
Yeah, copy. Thanks, Zoe.
Yeah, week 3 summary and tutorial prep. All right. Does that make sense for everyone? Is there asking?